impact maternal and fetal health. There are shared risk factors and overlapping mechanisms that lead to complex clinical challenges, and the aim for today's session is to examine the interconnected pathways and the management advancements. Right, so a few words about the definitions. I'm so sorry, there seems to be a bit of an issue with the fonts once again. So obesity is defined as a BMI of more than 30. It's a multifactorial disorder characterized by excessive adipose tissue accumulation, and it's associated with systemic metabolic dysregulation, including insulin resistance, dyslipidemia, and chronic low-grade inflammation. All of these increase the susceptibility to further metabolic problems. The metabolic syndrome is a constellation of interrelated metabolic abnormalities that predispose to cardiovascular disease and type 2 diabetes. This comprises hyperglycemia, central obesity, dyslipidemia, and hypertension. Gestational diabetes is hyperglycemia that's first recognized during pregnancy, predominantly manifesting in the second and third trimester due to the synergistic effects of pregnancy-induced insulin resistance and an inadequate compensatory insulin response. GDM is linked to adverse maternal and neonatal outcomes, including macrosomia, gestation, shoulder dystocia, and the need for cesarean sections. So there's a lot of importance behind managing these conditions predominantly in pregnancy. Obesity is our first point of call. In pregnant females, obesity exacerbates systematic inflammation and insulin resistance, compounding the risks for GDM, hypertensive disorders, and macrosomia. Obesity's impact on lipid profiles and glucose metabolism also complicates glycemic control, raising the probability of operative interventions. Metabolic syndrome. In the context of pregnancy, metabolic syndrome elevates the risk of preeclampsia and adverse cardiovascular events, while enhancing the susceptibility to GDM due to pre-existing insulin resistance. The components, for example, hypertension and dyslipidemia, can further have negative fetal outcomes as well. Gestational diabetes significantly increases the incidence of perinatal complications, including fetal macrosomia, this is just a repetition, neonatal hypoglycemia, and shoulder dystocia. And in the long term, it predisposes both the mother and the child to metabolic syndrome, obesity, and the eventual development of type 2 diabetes. So a few words about the pathophysiology of obesity, metabolic syndrome, and GDM. Obesity and insulin resistance, they both lead to a release of inflammatory cytokines, predominantly TNF-alpha, IL-6. There's also a negative impact of the adipocytes that lead to an increased release of leptins and adiponectin. Now, all of these things all add up together, leading to an inflammatory milieu in the body. And these lead to an overall increase in higher complications. This is just a slide giving you an overview of how obesity actually develops. There's an interaction between the genetic environment, age, ethnicity, and gender. There's excessive calorie intake leading to a decreased energy expenditure, which gives rise to obesity. This leads to ectopic fat deposition, both in the viscera, the liver, the pancreas, and the muscle, and at the same time leads to an increase in the adipocytes, an increased leptin level, decreased adiponectin, increased insulin resistance, elevated lipolysis, macrophage infiltration, increased release of inflammatory markers like TNF-alpha and IL-6, as I just mentioned. At the level of the pancreas, there's an increased insulin secretion and a gradual decline in beta cell function. At the level of the muscle, there's increased insulin resistance and a decreased glucose uptake. At the level of the liver, there's going to be increased gluconeogenesis, increased glycogenolysis, and increased hepatic glucose output, leading furthermore to increased steatosis, worsening of your VLDLs, a reduction in lipid oxidation, and this overall gross inflammation in the body. At the level of the stomach, there's increased postprandial ghrelin, decreased GLP-1 has also been hypothesized, and all this leads to a vicious feedback at the level of the hypothalamus. And as you can see at the bottom of the slide, there's no target tissue in the body that's actually spared. Cardiovascular, cancers, pulmonary impairment, GI problems, musculoskeletal, and further endocrine problems, these go sky high. So with regards to the pathophysiology, there's inflammation, there's been mediated metabolic syndrome. I've already briefly spoken about heightened TNF-alpha and IL-6. There's a resulting systemic inflammation that worsens insulin resistance, and there's a direct link to atherosclerosis and endothelial dysfunction. Obesity promotes insulin resistance by increased free fatty acids and adipokines. Insulin sensitivity reduces, leading to hyperinsulinemia and glucose dysregulation. Leptin, resistin, and adiponectin are key adipokines in obesity. High leptin, low adiponectin are associated with metabolic syndrome, and the endocrine role of adipose tissue impacts systemic glucose levels. During pregnancy, what happens is, because of placental hormones, insulin resistance is automatically physiologically elevated to provide more nutrients to the fetus. Pregnancy hormones amplify insulin resistance, therefore increasing the risk of gestational diabetes. Progesterone reduces glucose utilization by the tissues, and this hormone-driven adaptation predisposes to the development of gestational diabetes. Elevated free fatty acids and adipokines, as we've talked about previously, amplify pregnancy-induced insulin resistance, and obesity heightens GDM risks through disrupted glucose regulation. Now, there are long-term implications both for the mother and for the offspring. In women with GDM, there is substantially increased risk for the development of type 2 diabetes in the long run, metabolic syndrome, and cardiovascular disease postpartum, especially if the insulin resistance persists. Obesity and metabolic syndrome further compound these risks, leading to a heightened incidence of coronary artery disease, cerebrovascular events, and renal diseases later on in life. With regards to the fetus, intrauterine exposure to hyperglycemia may result in fetal macrosomia, increasing the likelihood of delivery-based complications, neonatal hypoglycemia, and respiratory distress syndrome. Longitudinal studies have also indicated that children born to mothers with GDM have an elevated risk of childhood obesity, insulin resistance, and type 2 diabetes, potentially due to epigenetic modifications influencing glucose and lipid metabolism. So there's a rationale, therefore, which focuses on early screening and early intervention. Timely identification of obesity and metabolic syndrome allows for the implementation of targeted interventions, which can be pharmacological, lifestyle-based, there are lots of options there, to reduce the risk of GDM and other pregnancy-related complications. Standard GDM screening typically occurs between 24 to 28 weeks of gestation, but in some cases you might like to screen earlier, for example, those who are either overweight or obese. Lifestyle and medical interventions would include, obviously, dietary modifications, physical activity, and weight optimization. These are topics that were spoken about previously by our colleagues who took the podium before myself, with medical nutritional therapy as a primary intervention. Nutritional counseling should emphasize, this is once again repetition, low glycemic index foods, whole grains, and lean protein to stabilize glucose levels and improve lipid metabolism. There are a multitude of complications that can occur with regards to GDM. These include preeclampsia, cesarean sections, fetal macrosomia, and in the long run, metabolic disorders in the offspring and maternal type 2 diabetes. So, a brief overview about lifestyle. Once again, we've already touched this. Focus on both diet and physical activity interventions. These improve insulin sensitivity, reduce blood glucose, and support weight management. Generally, if any of our colleagues are from obstetrics, in our part of the world, the focus is always when a female is pregnant that she shouldn't move. She shouldn't engage in any sort of activity, in any sort of exercise. This is a concept with which we as physicians, as clinicians, need to change. Healthy lifestyle throughout pregnancy, including physical activity, is definitely recommended. With regards to dietary management, high fiber, low glycemic index diet will prevent postprandial glucose spikes, and you need a balanced macronutrient distribution, which was beautifully highlighted by our physiology colleagues a few sessions ago. Exercise, once again, I'm touching this again. Moderate intensity exercise could include brisk walking or swimming. This would aid in improving insulin sensitivity, and it's safe in uncomplicated pregnancies. With regards to pharmacological management, once again we're talking about pregnancy here. Metformin is still first-line drug here, which enhances insulin sensitivity and is effective for mild GDM cases. It's commonly prescribed when lifestyle modifications are insufficient alone. The next step obviously would be based on insulin therapy, which allows for precise blood glucose control and is absolutely safe for fetal outcomes. Emerging therapies, Dr. Suhail touched very briefly on GLP-1 receptor analogs. These are now being investigated for pregnancy, and we have promising results so far. But since they're not incorporated formally into the guidelines, I really can't give you my 2 cents yet. But down the line, they're likely to be approved as therapeutic avenues, both for GDM and for obesity and pregnancy. So, before we move forward to lipid management in pregnancy, let's briefly touch about what physiological changes take place with regards to lipid metabolism during gestation. There's a normal increase in lipids during pregnancy. It's typical for cholesterol, triglycerides, LDL and HDL levels to increase to support normal fetal development. These lipids serve as energy sources for the fetus and are used for building membranes and other vital functions. With regards to trimester, in early pregnancy, lipid synthesis and storage increases. These are driven by hormonal changes, for example, increased estrogen and progesterone levels that promote fat accumulation to meet the demands of later pregnancy. In late pregnancy, lipid mobilization occurs as the fetus requires more energy. Stored lipids are released into the bloodstream to support fetal growth, which causes blood lipid levels to peak near delivery. And postpartum, a normalization occurs after delivery, with the lipid levels typically returning to pre-pregnancy baseline within a few weeks. And breastfeeding aids in reducing triglyceride and leads to a boost in HDL levels as well. There is, however, a concern of pathologic hyperlipidemia, and there are certain risks involved. In severe hypertriglyceridemia, if the female in question has triglyceride levels of greater than 500, severe hypertriglyceridemia poses significant health risks, particularly in pregnancy. High triglycerides can lead to acute pancreatitis and increase the risk of preeclampsia. Atherogenic potential does exist for small, dense LDL particles. These increase the risk of atherosclerosis and cardiovascular disease, and pregnancy-related lipid increases are generally protective, but an excessive SD-LDL can pose a risk for maternal cardiovascular health, and in the long term there's a risk of atherosclerotic coronary vascular disease as well. The crux of today's session is a change in the FDA guidelines. Back in July 21, the FDA removed the Category X label for statins, allowing for selective use in high-risk pregnancy cases. Statins had previously been completely contraindicated for fetal risk and fetal development, as cholesterol was essential for embryonic growth. However, for high-risk patients, the FDA now allows statin use in specific high-risk cases, such as those with pre-existing atherosclerosis, familial hypercholesterolemia, where the potential benefits would outweigh the risk. This change, this new approach, provides for more flexibility in cases where untreated lipid disorders can lead to adverse outcomes. And the decisions, however, need to be shared between the clinician, the patient, and the care team. There's emerging data on safety. Out of the statins, once again, a question arises, what could you choose? Should you need to use a statin during pregnancy? And the answer would be using hydrophilic statins, which would include rosuvastatin, pravastatin. These are generally better options than the hydrophobic statins. So we need to screen as soon as possible. Lipid levels should be checked pre-conception, especially in high-risk individuals during early pregnancy, particularly with those who have familial risk factors, for example, familial hyperlipidemia and obesity. You need to monitor during pregnancy with regular screening, and you may need to check for lipoprotein A levels as well, since elevated lipoprotein A levels can be a prothrombotic state. So, in the interest of time, I'll have to rush quickly. I believe the bell went off behind me as well. I was told we had 25 minutes, but nonetheless. So we do need to use careful medical management, especially in high-risk individuals. You may contemplate the use of statins. You may contemplate the use of ezetimibe. You will require dietary adjustments. You should recommend exercise and physical activity. Approved medication, bile acid sequestrants are completely safe. Omega-3 fatty acids are recommended. Fenofibrate is generally limited when the TGs are above 500. We've spoken very briefly about rosuvastatin and ezetimibe. The combination is used in cases of severe hyperlipidemia and very high risk for atherosclerosis. Its hydrophilic nature may make it a safer choice overall, but the jury is still out. Mind you, the guidelines are still being updated, but I foresee that at some point in time, for high-risk patients, they will be approved as well. In lactation, generally we recommend stopping these therapies because there's a potential transfer into breast milk. Bile acid sequestrants and omega-3 fatty acids remain safe overall. The implications, the reason why we're so concerned is there is a chance of in utero atherosclerosis as well. Elevated maternal lipids can affect fetal endothelium, potentially predisposing the offspring to atherosclerosis, and there is an epigenetic influence as well. High maternal cholesterol levels may impact fetal circulation, fetal cholesterol metabolism, increasing the risk of atherosclerosis down the line as well. And that brings me to a conclusion. Thank you ever so much.
Thank you, Dr. Ali Arif, for your wonderful presentation. I apologize for the misinformation to you about the time. We are grateful for your expertise, which adds great value to our session. Now, I request our expert panel to please share their thoughts on the presentations.
First of all, I'd like to congratulate Pakistan and Diabetic Association and the Lyallpur Diabetic Forum for conducting this a very important scientific seminar. This was a long session. I think 8 presentations in one session was too much. But we started this morning with Dr. Asma, and she gave us some worrisome figures about the prevalence of diabetes, a high prevalence of diabetes in Pakistan. After that, we have some excellent talks about the nutrition and the lifestyle management by Dr. Shahla, Professor Huri Ahmed, and Professor Masood Bhatt. Then we have some excellent talks about the management by Dr. Qamar Masood, Dr. Suhail Anjam. And at the end, we have a good talk about the metabolic syndrome and obesity by Dr. Ali Arif. I thank all the speakers and for their excellent talks. Being a hepatologist, I just want one point to share with you. But I felt in the talk that there was very less emphasis on the fatty liver disease or the steatotic liver disease. Dr. Masood, कमर मसूद साहब ने CKD और कार्डियोवास्कुलर डिजीज़ की बात की. बीइंग ए हेपेटोलॉजिस्ट व्हाट आई सी इस वक्त दुनिया में जो फैट लिवर सिरोसिस की सबसे बड़ी वजह है वो दिस डायबिटीज़ एंड मेटाबॉलिक सिंड्रोम. एंड वी आर डीलिंग डेली पेशेंट्स with end-stage liver disease due to diabetes and metabolic syndrome. और फैसलाबाद में यंग डॉक्टर्स बैठे हैं, शायद बहुत सारे डॉक्टर्स को इल्म ना होगा कि इस सिटी में a professor of medicine who was diabetic, expired, who was never had viral hepatitis, he presented with upper GI bleed, found to have an untreatable hepatocellular carcinoma, and he expired within the next 4 to 6 months. And he was a professor of medicine, my teacher, in this city. So this tells us कि हम अपने diabetic patients की जो management करते हैं, we should be taking care of their eyes, we should be taking care of their heart, we should be taking care of the kidney. But being a hepatologist, मैं सिर्फ ये message convey करना चाह रहा हूँ कि जो liver diseases हैं, due to the diabetes and metabolic syndrome, that is a problem. हमारे medical ward भरे हुए हैं उन cirrhotic patients से जो diabetes और metabolic syndrome की वजह से end stage liver disease पे पहुँचते हैं. Thank you very much.
Thank you, sir.
Thank you. I think the organizers has given me the point, although I was not planned the panelist yet. So I think I must say and endorse what Dr. Shahid Rasool has already said. The only thing that I would recommend after seeing this huge number of presentation in one session, that we should have 2 or 3 psychiatrists also. Why? Because our knowledge is not coming into practice. This is actually the crux from last 2 days, and in multiple meetings that I said, I come to realize that we know things, but we are not acting according to the things that we know. Yesterday, last night, dinner was a good example of that. How people rush towards the meal, what type of meal that we had, and how we were dealing with our kids and the family along. So our practice has to have the impact of what we are teaching, what we are listening, and what we are doing. So if this need to be in practice, then I think rest of the things will improve by itself. Thank you very much for a very, very gallant effort that the show people have already put into. Thank you.
Thank you, sir.
Thank you very much.